Hi, my name is Courtney Phillips, and I'm the Program Director of Urology at Northwell Health, Lenox Hill Hospital in New York City. I specialize in endourology and urologic oncology, and I've been doing this for about 15 years. So PSA stands for Prostate-Specific Antigen. It's a chemical that's made by certain cells in the prostate. And when you develop prostate cancer, it's actually a cancer of those particular cells. We can measure this protein in the blood. And the reason why sometimes we measure it, well, there's really two reasons. One is to help screen for prostate cancer, and the other is to help track our treatments if you have prostate cancer to see how well you've responded. So a normal PSA will vary depending on a lot of factors. So it'll depend on your age and your prostate size. Before we had this kind of level of knowledge about PSA, we used to just say 4. 4 was the cutoff. There's a lot more subtlety to it now. So, for instance, somebody in their 50s should really have a PSA less than 2.5. Some people would say less than 2.2. As you get older, a normal PSA for you will increase. So my level of tolerance for someone in their 60s would be a higher PSA, in their 70s, etc. Also, if you have a larger prostate, I'm going to tolerate a higher PSA as well because you have more cells to make this chemical PSA. Sure. So your PSA can rise for a number of reasons. Anything that irritates the prostate, so prostatitis, urinary tract infections, can increase your PSA. Things like your prostate size, just by having more cells in your prostate, that can increase your PSA. We know that PSA also goes up with age, and we think some of that has to do with the fact that your prostate does keep growing for a lot of your life. And it can also go up for cancer. So there are a lot of reasons. I like to tell some of my patients that if I checked your PSA every day for a month, it might be different every day. Yes, it is possible to have prostate cancer even if your PSA is low. There are certain types of prostate cancer, and they're really, really, really rare, that don't increase your PSA. There's also the chance that you have a very early or a very non-dangerous prostate cancer and you'll have a normal PSA as well. I think one of the things to stress is that prostate cancer, while it's the most common cancer in men, it does not cause the most number of deaths of cancer in men. So a lot of people, it's not like colon cancer, breast cancer, ovarian cancer, pancreatic cancer, where if you have it, you'll die of it if you don't do anything. Prostate cancer is a cancer in men where a lot of people will live with it and never die of it. So free PSA is a subset of PSA, and having a higher subset of free PSA can be a good thing. We use the free PSA value when your total PSA is between 4 and 10. We know that PSA as a predictor of cancer isn't the best. It really isn't by itself, and so we've started to look for other adjuncts to use with PSA. PSA density is the amount of PSA per prostate size, PSA velocity, how fast your PSA goes up. And free PSA is one of those adjuncts that we look at. We like to see a higher percent free PSA, but again, we really only use it if your total PSA is between 4 and 10. This is a really hard question because I think that PSA has gotten a lot of bad press. Is it reliable? It's not the most reliable. I mean, certainly there are other markers that for other cancers that perform better or are more reliable than PSA. So we've really tried, a lot of research has been put into trying to find adjuncts, additional things that we can use in addition to PSA because it just doesn't do well by itself. I'd say it performs much better if I know someone has cancer, I treat them, and I follow their PSA. It's actually very good for that. Well, the first thing you have to do is get it repeated, okay? And that's actually in the American Urologic Association guidelines. I never act on just one PSA. I always repeat it. But then what you do is you see a urologist and you have a discussion. We do an exam, we talk about your risk factors, and risk factors can be being of African American race or Caribbean American race, having first degree relatives like a father, brother, or son with prostate cancer, especially if they were diagnosed at younger ages. Being BRCA positive is a risk factor. So we look at that and we look at the full picture and we decide if you need further testing, such as an MRI. I think the decision to screen your PSA or for prostate cancer at all has to be a shared one. It has to be shared between your doctor and yourself, your goals, your health. For instance, we try not to screen people for prostate cancer who we don't think will live for at least 10 years. And I think that's really important because it can lead to a lot of over testing. We know that, again, prostate cancer for a lot of men is a disease that you die with and not of. So we don't want to over-treat people, but we still want to get men who have it and potentially have what we call clinically significant or potentially dangerous prostate cancer. We want to get them to treatment without over-treating people who don't have that disease.